Welcome to the Clinical Education Initiative podcast, Conversations with CEI, where we feature conversations with clinical experts, their experience and insights on current health issues in the areas of HIV, primary care and prevention, sexual health, hepatitis C, and drug user health.
Hello, and welcome to the latest episode of Conversations with CEI. I'm Marguerite Urban, and I'm an infectious disease physician at the University of Rochester, and I'm your host today. I'm here with Dr. Jason Zucker, and I'll let you introduce yourself, Jason.
Morning. Thank you for having me today. I'm Jason Zucker. I'm an adult and pediatric infectious disease doctor at Columbia University, and I also serve as the assistant medical director from the New York City STI Prevention Training Center. Thanks for having me.
We're really happy to have you. I'm in a similar role here in Rochester, where I'm the medical director for the CEI Sexual Health Center of Excellence, and that's what really brings us to our conversation today. We're going to talk about some emerging STIs, particularly a skin infection that really has captured the interest of the internet and of lots of clinicians. Just to set this up of why we asked you to be here, Jason, today, as we have an annual conference for our CEI Sexual Health Center. And this year, our conference was in May, and we offered a session called STIs, the List is Growing. And it turned out that session had attendance really going out the door. We couldn't fit everybody in the room. And so shortly after that, we had a second episode where we called it STIs, the List is Growing. And that was a webinar presentation that will be available on our CEI website. And again, the attendance was really overwhelming. And the very first presentation related to a paper that you published back in 2024 about a new tinea infection. So maybe you could just set that up for us and tell us a bit about that paper.
That paper was an MMWR focused on Trichophyton mentagrophytes 7 or TM7, which we'll say for the rest of this podcast to make things a little bit easier. And it is a fungal infection that's from sort of the same genus as typical ringworm. You see these red lesions on people's skin that we think about coming from either animals or locker rooms. But what we started to see in New York City was that we were seeing this infection spreading between humans, particularly in people who were having sexual contact, causing these really itchy ring-shaped skin lesions in the genital areas, the buttocks, and they were not improving with our typical treatments. So short courses of topical or oral antifungal therapy was not necessarily making them better. And that's really what raised some red flags across the city. And so we started to culture them, and we identified this fungal infection called TM7, which we had typically thought about in Asia previously, but then had started to see more and more infections among men who have sex with men in Europe. And now we're seeing them here in the United States as well.
Yeah, so was this all within your practice, or it was citywide, and there's sort of a network of clinicians that communicate to notice a change?
Yeah, so we started to see a few of them in our clinic because we work in a sexual health clinic as you do. Whenever we hear about things happening in Europe, we start to pay attention. A lot of our patients travel back and forth and engage in sexual activities over there and then come back here. So we always begin to pay attention. Concurrently with that, the group at NYU, the dermatology group there, was also paying close attention to this. And so they had reached out asking if other people were seeing this as well. And that's kind of how that group came together that ended up publishing that article.
And this was published back in 2024. And are you still seeing this now in 2025?
We are still seeing cases occasionally. It has not resulted in a large, widespread outbreak, but I actually think we just had a case the other day. So we certainly are still seeing cases scattered here and there. The other thing is it's also very hard to identify for sure. Fungal cultures are hard to obtain. They take a really long time, and they're not always done by our clinicians. And so sometimes people are just treated empirically. And so there's probably more out there than we're actually diagnosed in.
And would you say that it looks the same as other tinea, and it's really the sexual history that gives you the clue? Or do you feel like the clinical appearance is a little bit different?
I feel like it can be similar, but it certainly seems a little bit more severe than we sometimes see with more traditional ringworm. They're sort of more red and more inflamed than we typically see. And then, as you mentioned, the location is really important because the genitals, the buttocks, the face are very common areas for this, where we typically saw ringworm on the hands and feet before. But they do seem a little more inflamed than what we would typically expect.
Yeah, that the paper included some photographs that were really, I'd say, pretty classic for tinea, but maybe just slightly larger than sometimes you see, and maybe a little more prominent. It's interesting, by chance, on the day we're recording this, there was a pre-release of an article in Emerging Infections, and that refers to a survey that was done on the Emerging Infections Network, which I suspect you're probably part of. And that's a network where there's sort of questions and answers among a group of interested infectious disease clinicians and clinicians in related areas. And so the CDC did a survey of that network asking about awareness of TM7, and they're just publishing that now. And there were just over 100, about 120 respondents. And in this probably pretty informed group, because they're part of an emerging infections network, it seemed that 65% had heard of this infection, but only 5% had actually seen someone, which ended up only being 5 people. So that's pretty small and makes you wonder if we're maybe missing some of this.
I certainly think we are. Was that article written by Dr. Jeremy Gold? Was he the first author?
He was the senior author, the last.
Senior.
Yeah.
Got it. Excellent.
Yeah.
Former resident in Columbia who worked with us here before going to CDC for EIS and worked with us on the MMWR that we published as well. We talked before how we think it's a little bit more severe maybe, or looks a little more inflamed than regular ringworm. At the same time, I certainly don't think you can easily distinguish TM7 from other types of trichophyton just visually. And so to really know, we really need culture. And most sites don't routinely do culture. They just treat people with antibiotics and hope that they improve. It's really only when they fail traditional therapies that people are likely to get culture and we're more likely to identify this organism. The other thing is right now, it seems to be really maintained within gay, bisexual, and other men who have sex with men networks. And we've not seen it in that many areas of the country yet. So it may be that it's primarily in New York and other sort of high density areas like that. And we may not be seeing it as widely as other things.
How about co-infections with other STIs? And I was thinking actually of Mpox, which is also sort of re-emerging right now to be a little bit more common.
In the Paris series by Jabet et al., many of those patients had STIs at the same time. I probably don't remember exactly what percentage they had, but they had high rates of co-infection with other STIs, same in the Spanish cohort. In our cohort, they did not have other sexually transmitted infections. At the same time, they are patients who are in our clinic who may have had STIs in the past and just did not at the time of their diagnosis.
Yeah.
But we certainly have seen it in the other international, European cohorts in particular.
So I guess for our clinicians that are listening, one take home is to just know about this, that this is circulating among men who have sex with men, particularly associated with travel into Europe and maybe Asia as well. To think about not just routinely treating, but making sure that you obtain a laboratory test, even though, as you said, fungal culture takes quite a while. But if you have a treatment failure, at least you have that culture percolating. And for treatment, if you see a man who does have sex with other men and maybe was recently in Paris and presents with tinea, are you treating empirically for this?
I think that's probably been the biggest change in our practice. In our sexual health program now, when we see people coming in with tinea, particularly in the genital or buttock area, we're presuming that it's TM7 and we're starting them on oral terbinafine. And though we're planning for a long course of treatment, it's not just 2 weeks. I think it was the Spanish cohort that showed 0% cure at 2 weeks of treatment, and that you really needed 4 to 8 weeks of treatment if you wanted to see a good success. Yeah, it was both France and Spain, actually. Short course at 0% cure rate, and recurrence was really common if treatment was stopped early. So we generally plan to treat people for 4 to 8 weeks, starting with 4 weeks, reevaluating them at the 4-week mark, and then continuing if there's really any sign of ongoing infection.
So what is your counseling then about sexual contact in that 8 weeks?
It's really hard. We primarily counsel about trying to keep the lesions covered. It's a harm reduction approach. We'd love to tell people don't be sexually active, but we know from years of experience that if we say that, then they're going to do kind of nothing. But I think what's really important is counseling them that they want to avoid skin-to-skin contact with these lesions. So find ways to keep them covered and protected, if at all possible.
And how about laundry? I guess that would be the same as any counseling regarding ringworm.
That's right. Yeah.
About household contacts. Yeah. That's all about TM7, but there's another one, right? Another trichophyton that is emerging as well. And maybe we could just mention that a little bit, Trichophyton indotineae. Have you seen that as well?
We've seen one case of that. That is not necessarily being sexually transmitted, but it's really important to know about because of differences in the way we treat it. While TM7 also started in Asia, we're now seeing it really in Europe as well as here in New York City. Indotinia has primarily remained in India and South Asia. We're seeing limited cases in the Europe and US. And it's, again, transmissible through skin-to-skin contact, but we're not necessarily seeing sexual transmission. I think there was one case report so far about sexual transmission to a heterosexual female, but we're not seeing sort of that more widespread sexual transmission like we are of TM7. The important reason it needs to be on your differential, though, is that it's generally terbinafine resistant. So if you have a patient that you think has TM7 that's failing terbinafine or failing to improve, you might want to think about switching them to itraconazole for Trichophyton Indotinia. It's also why it's so important to get that culture, even if it won't come back for 4 weeks, because then if your patient is not doing well or not improving, you at least have then an identification that can help you better direct how you're going to change your therapy.
You did mention that heterosexual transmission, but that was a travel-associated
Yes.
infection and skin-to-skin contact that happened during sex. I've not seen any of that, but from what I've read, that really does look like a little bit different animal. The lesions are larger and cover a sort of more surface area that might give you a bit of a clue, along with travel, that it might be this more unusual tinea.
Yeah, and I think for that one, travel is really the big key. The problem with travel, though, is that what if somebody you were with traveled, right? And so taking an adequate travel history is always really challenging. And it's important that even though we're seeing it less frequently, that is on our differential, especially for people who are not improving with our initial treatment.
As I was just reading through the literature preparing for this, I came upon the registries that the CDC has set up. And there is a registry for resistant fungal infections, and particularly for TM7. Maybe you want to just tell us a bit about that.
Yeah, so obviously, because this is an emerging infection in the United States and something that's potentially sexually associated, if not sexually transmitted, there's groups at the mycosis group as well as the STI group that have worked together with University of Alabama to develop a registry for these cases. And the goal is to put together as many of these cases as we can so that they can do a better job of both understanding the epidemiology, recognizing when cases or if cases are increasing, as well as to better understand treatment outcomes so that we can provide better guidance around these. Again, most of the case series right now, the large case series is like 45 to 50 patients. We certainly need more data if we want to be able to better understand this disease and provide really concrete recommendations on how to handle it.
We do know that resistance is spreading among fungal organisms, and we hope to not have a widespread outbreak of highly resistant organisms. I've been asked by some patients when they're diagnosed with tinea of what to tell their partners. Is there anything that their partners can do if the index patient, if you will, is diagnosed with tinea, but the partner does not have any evidence of infection?
Yeah, we know that this transmits pretty well from partner to partner. We know from both the French and Spain cases that there were clusters among sexual partners. And we do try to recommend patients avoid skin-to-skin contact until lesions resolve, so keeping them covered and other things. We're not formally recommending partner treatment, but I do recommend that partners come in and be examined. It's helpful for them to come in, have an exam, and if we see anything, then start treatment early as opposed to waiting. And I think that's probably the best advice right now. We don't have guidance on partner treatment yet, but I think partner evaluation is really important. A trained clinician may see something that looks like an early rash before maybe somebody will identify it themselves, or they may be able to see parts that people are not readily able to view on their back or backside that they can't view well themselves. And so coming in for a full exam, I think, is really helpful. And then just after the exam, being aware that it still could develop, because especially if they're in the same household or still sexually active, and to come in early if they start having any symptoms.
In my reading about both of these infections, I've read some comments about why these have taken off, particularly in Asia. And one of the theories is that there is widespread availability of both antifungal creams and steroid creams and combinations of those two over the counter in Asia. And I've seen some commentary, particularly that there's concern that sort of maybe misuse of steroids in a fungal infection have sort of led to this ability of the infection to worsen and develop resistance to some of the other antifungal agents. What do you think about that?
Yeah, I think that it's one of the reasons it's so important that clinicians be aware of this. For common ringworm infections, we frequently recommend topical antifungals. we know that for these two infections, topical antifungals are very unlikely to be successful. And like you said, may be contributing to resistance. And so for people who are sexually active with lesions on their genitals or butt, we really need to think carefully about the possibility of TM7 and provide systemic antifungals as opposed to topical. And same with endotheliae. Steroids definitely have been demonstrated to worsen this disease. And so again, people commonly give steroids for common ringworm to reduce the inflammation. In this case, once again, if you're thinking about TM7 or endotheliae, we should not be using steroid creams as they can worsen disease. We really want to think about systemic antifungals and avoiding topical steroids.
Yeah. Steroid creams really can be a bit of a trap because they do reduce inflammation. There's this transient improvement before the worsening. And so that can make for a confusing history if you're really not sure that it's tinea in the first place. I guess we should mention that there are some differential diagnoses. Same as with any tinea, you might consider psoriasis or some sort of eczematous rash. The pictures that are in your article are pretty classic tinea, but we all know in the world of medicine, there's lots of gray areas where things don't look classic. I think the hope would be that clinicians are aware that TM7 and even endotheliae are here in the United States, although not widespread, we believe. These are not reportable infections to your local or state health departments. We don't really have a good sense of how much there might be. And that's why it is important, I think, if you are seeing patients to contribute to that registry at the CDC so we can kind of get a handle on it if this infection is spreading in our areas. And just a final recap, like if you're seeing tinea that appears to be sexually transmitted, it is really important to get a sample and an accurate diagnosis of which specific organism it might be because the treatment differs. And if you're concerned for TM7, as Dr. Zucker says, they've changed their practice and are not treating with topical agents right now, but really treating with oral terbinafine for quite a long time, 4 to 8 weeks. So any final words of wisdom for us?
Nothing else, just the usual. All of these things require a high index of suspicion. The first step is just making sure we think about it when we see a patient who might be vulnerable or might be exposed to TM7. And if you know that it's a possibility, then you can think about the right thing to do.
Okay, great. And I guess one final word, the CDC does have a very helpful website, and really just if you Google TM7, you'll probably pull that website up. And certainly if you Google CDC and TM7, you'll pull it up. So there are some good pictures and helpful tips there. Well, thank you so much, Dr. Zucker, for being with us on Conversations with CEI. We are always happy to collaborate with you and with the New York City PTC. So we wish you well, and thanks again for joining us.
Thanks for having me.
Thank you for tuning in. Join us next time for a new episode of Conversations with CEI. Visit us at ceitraining.org and follow us on CEI social media platforms.